Good morning, dear colleagues, excellencies, ladies and gentlemen. Let me begin by saying that on behalf, of course, of the permanent missions of the state of Qatar, Poland and Turkey to the United Nations, Unicef, Hamad bin Khalifa University and Autism Speaks, I'm so delighted to welcome all of you to this virtual discussion to discuss the state of art in digital health, artificial intelligence, and machine learning technologies for the identification, assessments, and interventions for children with developmental delays and disabilities. I would like to first, of course, thank all of our panelists for being here with us today and to share their knowledge and experiences in this important field. Throughout the years, the state of Qatar has proven its leadership in research, development, and innovation that benefited persons with disabilities. In this regard, I would like to acknowledge, of course, the groundbreaking research undertaken by Hamad bin Khalifa University, a member of Qatar Foundation for Education, Science, and Community Development, on artificial intelligence and machine learning as key drivers of innovation across many industries. HBKU, of course, research capabilities and work on technological interventions such as artificial intelligence, augmented and virtual reality, are improving the learning and attention span of children with autism spectrum disorders. Dear colleagues, we will now hear from experts present here today on how new advancements in AI and ML research can be a force for good for children with disabilities, bridging inequality gaps. And we will discuss the establishment of a global digital health consortium for children with developmental delays and disabilities. I will now hand over the floor to Dr. Andy Shi, who will be moderating our panel today. Dr. Andy is the Chief Science Officer of Autism Speaks. As you may know, Autism Speaks, of course, is the largest autism research organization in the United States. It sponsors autism research and conducts awareness and outreach activities aimed at families, governments, and the public. Since joining Autism Speaks in 2006, Dr. Andy supports ministries, governments, agencies, and leading non-governmental organizations in more than 70 countries to deliver better outcomes and quality of life for tens of millions of individuals and families. Dr. Andy, the floor is yours.
Thank you very much, Your Excellency. Excellencies, colleagues and friends, ladies and gentlemen, more than 95% of autistic people and their family live in low and middle countries, where a pervasive lack of capacity to deliver timely access to effective support and services remains a key barrier to well-being and better outcomes. While ongoing capacity building efforts like the Caregiver Skill Training Program launched last week by WHO, UNICEF, and Autism Speaks are helping to address some of these needs, the desperate and ongoing impact of the pandemic on children and families with autism and other developmental disability highlight the urgency and scale that we need to act to overcome this major challenge in access to care. Recent advances in digital health research, including AI and machine learning, promise unique opportunities to bridge that capacity and service delivery gap. The time is right for the global community to come together to accelerate research and implementation of digital solutions to promote health inclusion for all our children and their families. Today, we begin that critical conversation about how to mobilize our collective knowledge and work collaboratively to foster innovation and fast-track the implementation of solutions to help our children and family with developmental disability to reach their full potential. Thank you. Now I have the pleasure to introduce our next speaker, Dr. Lu-Wei Pearson, a pediatrician serving UNICEF headquarters as Associate Director of Maternal, Newborn, Child, and Adolescent Health. Dr. Pearson.
Thank you, Andy. Thank you, everybody, and warm greetings on behalf of the entire UNICEF family. It's a great pleasure for me to speak on behalf of the UNICEF Health team this morning. Your Excellencies, colleagues, and friends, for UNICEF, it's critical that every child reach her own or his own potential, and they need to receive all the required health, nutrition, protection, education, and all the other services. And we are aware that in high-income countries, including that in Qatar, most of the children with special needs, with disabilities, and with developmental delays have been taken care of. And we are moving to the next steps, using AI and digital technology to further to meet their requirements. In low-income countries, however, we're really talking about the building the basics, the primary health care system, the foundations, even just clean water, electricity, or communication, and the required human resources are not available. So often we could not meet the need of the population, let alone those with special need, with disabilities, including children suffering from autism. We also believe in to break different program silos, right? Because UNICEF is an organization for children. It's not health only. So we believe the importance of the special window during pregnancy and the first 3 years that are critical for brain development should be continued to childhood, to adolescent period, and the early adulthood. And we are aware the breaks of those linkages and the unavailability of services may have cost us a lot, including 10%, estimated 10% of the children in poorer countries do not receive the required services. So what UNICEF can do? I want to be concrete, to be mindful that we work in over 100 countries for health, education, nutrition, child protection, and different programs. So I have some reflections where we can offer so that colleagues from different countries can collaborate with us. And likewise, we collaborate with academic institutions and different countries, high, low, and middle income. First of all, I want to talk about birth registration. And a simple booklet like this, and maybe not digital, it's hard to focus. A booklet of MNCH booklet to register every pregnancy and monitor all the milestones, immunization, and the treatment should be made available either manually or digitally for every child, every mother, and every family. And every birth, including the birth of a child with disabilities, should be registered to have information system upon birth. Social protection system is also important. I remember visiting Brazil during the Zika outbreak. And at that time, the Brazilian government decided to compensate $100 per month to the household with a child diagnosed with Zika. Why is this important? Because as Andy said, most of those children live in the poorer segment of the society. For this case per se, Zika is the urban slums, the household living with more frequent exposure to mosquitoes. So those social protection system enabled the parents to take care of the child with Zika, severe or mild. Access to social services is important. Now we talk about WHO has the ambitious goal of UCI, and including children in the essential services, include them in the health insurance is critical, because sometimes those diagnostics, treatment, and care and support can cost a lot of money to them. We acknowledge the importance of technology. Whenever needed, whenever it's suitable, not to replace the critical needs of skilled human resources, to scale them up and find the best method for different countries to speed up what we want to do. Also to remind us that UNICEF's huge contribution through our supply division based in Copenhagen. 50% of the vaccines of the world go through UNICEF. All the COVID-19 vaccines and most of the vaccines for childhood immunization go through the UNICEF channel. So it can be the assisted technologies, AI or wheelchairs. We can help to shape the market, to bring the price down, to meet needs of those families, and so that they have the opportunity for both physical and mental health. We can also offer our knowledge and experience in implementation research, in knowledge management, and we can support experience exchanges among countries and with academia institutions so that the experience and lessons learned can be applied in the programs. So with this, I wish you a great deliberation today and a successful webinar. Back to you, Andy.
Thank you so much, Dr. Pearson, for those important words. We'll have 3 sessions this morning, and session 1 and 2 will focus on identification, assessment, intervention, and care. We're very fortunate to have an opportunity to learn from 4 distinguished experts, all leading researchers and practitioners in this area, followed by a facilitated interactive conversation. Session 3 will then follow, and it will involve reflections and perspective from several key stakeholders, including policymakers, community organizations, ethicists, and research professionals. Now, without further ado, please allow me to introduce our first speaker, Dr. Dina Al-Thani. Dr. Al-Thani is Assistant Professor at the College of Science Engineering and Director of Interdisciplinary Graduate Program at the Hamad bin Khalifa University. She received her master's degree in software engineering and PhD in computer science from University of London. She's a member of the World Health Organization Technical Advisory Group on Assistive Technology and part-time research innovation consultant at MATA, Qatar Assistive Technology Center. Dr. Dina is keen to see the impact of research on inclusive design and assistive technology in Qatar and in the world. Dr. Dina, the floor is yours.
Thank you very much, Andy. First of all, I would like to thank you for the very kind invite, and I would like also to extend my thanks to the Qatar mission in the United Nations and Her Excellency Sheikh Alia for this great initiative in organizing basically and supporting this important initiative. I would like to please share my slides if that's possible, or thank you very much. So I'm very delighted actually to come and speak about an important topic and a very close topic to my heart, basically, which is designing technologies for people with disabilities. That's a core area of mine that I've been working in the past 14 to 15 years. Next slide, please. So I'd like first to start with presenting our university. I come from Hamad bin Khalifa University. I joined almost 6 years ago, and this university actually was initiated or founded by Her Highness Sheikh Hamouza bin Nasser in 2010 to be a catalyst of a change in Qatar as well as in the region and the world. It is a research-intensive university that aims to transform the society and the world around it to a world that is basically better supporting to its different individuals. The vision basically of this university is to be a research-intensive university, and therefore most of our programs are of postgraduate programs and research-based programs. We host 6 colleges plus 3 national research centers with world-renowned scientists in the different fields from all around the world, in fact, to work toward a Qatar knowledge-based economy, which is the vision of the state of Qatar of 2030. Next slide, please. So speaking about the topic today, which is the importance of leveraging on research in digital health and AI for disability to the whole world around us, to the community around us, and not to leave these services to the people privileged who can afford it. So basically, the idea was how can we expand the knowledge to the world around us? And as I said, this is a core, basically, belief of Hamad bin Khalifa University. As you may all know, digital health, which spans from telemedicine, AI for digital health, wearables, robotics, all fall under the umbrella of what we call today digital health or e-health, is here to stay. And in fact, all have in their underlying baseline AI as an engine for how it is working today and how it is operating. We can see it in the world around us. And in fact, it will determine the future of medicine, as we can see in the world already. We are seeing on the world around us. It's changing the world around us. It's changing our own lives on how we deal with our personal health records, on how we look at our personal health records. Now, the human health and the human data is sort of centered around these technologies, and we make decisions based on this, whether it is on a health setting or in a social and a living setting. We have access to our own data, and we hence make a decision in our lives, on our daily lives, based on these data, and basically we envision that the delivery of health services will change dramatically as these technologies are integrated in the different health ecosystem, and hence we should not leave anyone behind, and we should think about the world around us and how to provide them. And we also anticipate that this will lower the cost of services of health. Next slide, please. Talking about health, we would expect discussing patient information. Nowadays, patient information is huge. In fact, data is collected on all levels of healthcare services, from patient health records to scans to blood counts, and as you go in the different health services available in the system. So what can we do with this data? In fact, this data is revolutionizing the healthcare delivery around us, and we can see it. And we could define AI for health from two different perspectives. What I call here the micro level, which is the human-centric, the data we collect from the human being, from the body, and through the different sensors and the wearable technologies and the scans and other aspects, and the micro level, which is the population based. When we look at the micro level, there are different applications, from clinical decision support systems, where doctors can use such systems to help diagnosing, to help understanding a condition, accurate diagnosis. Many systems are here today to help accurate diagnosis of different conditions, early detection. And here, since we have many of the big names with us here in early detection of autism, we can know that AI can help in early detection, for example, of autism through the data collected from eye tracking and videos and so. We could also predict disease onset from the data we collect, defining different treatment protocol and assessment. when we look at AI for health from a macro level, from a level of a population, there is a lot to be done from the public health perspective. For example, predicting a spread of a disease, as we have seen and heard with the COVID-19. Biomarkers discovery is actually one of the biggest achievement for machine learning. And as you may all know, machine learning is a way of algorithm to grow and strengthen through data. And through machine learning only, in fact, we were able to study omics, analyze omics, interpret them, basically discover new diseases, discover the relationships of these diseases and sub-diseases. So basically, what I'm trying to say here, that AI has a huge potential in changing the delivery of healthcare services. Next slide, please. Talking about AI for disability, which is obviously the closest to my heart here, as I've been working in this area for a long time, we have noticed that actually AI has changed the realm of research for disability and technology and assistive technologies. And it could be defined or clustered into the 6 clusters in front of us. And it can, hence, when it is used in these different areas, it can improve the life of people with disability, whether from a health perspective, an educational perspective, or even a social perspective. For example, access to information and communication. There are a lot of studies nowadays and developments in the use of AI, for example, in automatic image detection for the blind or sign language for the deaf, and so. When we speak about inclusive teaching and learning, there are a lot of AI-based applications and research study that actually as well my team is working on in basically enhancing personalized learning for people with disability, whether it is autism or other conditions. Accessibilities of environment, and that's a huge area of research where AI could play a big potential. Caregiving, robotics could play a great deal of services when it comes to caregiving. Screening, of course, and diagnosis and rehabilitation and habitations for people with disabilities. So as we can see here, there is a lot of room of improvement, a lot of room for us as researchers, for practitioners to implement, for us as researchers to discover in this realm. And that's what we hope to see as a change in the world around us. Next slide, please. Coming to this point, I would like to introduce few or couple of the projects we have at Hamad bin Khalifa University that my team is leading. So the first project we started almost 4 years ago. In this project, the idea was to investigate whether a child with autism spectrum disorder is giving attention during learning. We based our research on basically the hypothesis that looking at a child's face and the way he or she expresses their emotion through their face and eye movement would tell us whether they are giving attention or not. From our experimental work with children with autism, we realized that children with autism give the attention in a very individualistic way. It's not that they don't give attention. In fact, they give attention, but in a way that is very individualistic from one child to another. We used for this research machine learning and artificial intelligence. Me and my colleague here with us today, Dr. Marwa Karakai, we worked in this area with our research group, and we had basically many achievement, whether research papers or IPs on this area in how can we develop a machine learning model that assess attention of a child during learning. Our next project basically is to develop a web-based application that we hope to have to the world around us in the next couple of months. Next slide, please. Last but not least, we also used augmented reality as an approach to personalized learning for children with autism. We worked closely with speech therapy for children with autism with a center here in Qatar, which is Shifallah Center. It's one of the biggest centers here in Qatar to support children with autism. We work very closely with them in identifying a personalized learning app in which every child would have their own journey of learning using augmented reality and some animated robotic character that actually help to engage the child. The app, as well as in its final development phases, in which we're planning to fully launch with the Shifallah Center and other centers who are interested with working with us. Again, this is something we can think of in regards to the consortium. Thank you very much, Andy, for the opportunity.
Thank you so much, Dr. Dina, for sharing your excellent work being done at KU. Our next speaker is Dr. Julia Parrish-Morris. She's an assistant professor of psychology and psychiatry at the University of Pennsylvania and a scientist at Center for Autism Research, Children's Hospital, Philadelphia. Using techniques such as virtual reality, computational linguistics, and infrared eye tracking, Dr. Parrish-Morris uses advanced technology to explore the intersection of language and social cognition in children with neurodevelopmental disorder like autism. Dr. Parrish-Morris, the floor is yours. Let me bring up your slide. You can mute.
Okay, now I'm unmuted. Thank you. Sorry, I was getting a notice saying the host wasn't allowing me to unmute. Hi, everyone. Thank you so much. Thank you so much for that wonderful talk, Dr. Althani. That was really, really inspiring. So I'm super honored to be here today. I appreciate the invitation. This is a wonderful, wonderful effort. And I am very happy to present some of the things that we have been working on at the Center for Autism Research at the Children's Hospital of Philadelphia now for coming up on 10 years, trying to figure out ways to collect data from families while they're in hospital visits. Because, you know, we work at this large children's hospital. We have tens of thousands of children going in and out of our hospital system. And every visit is kind of a missed opportunity to quantify a little bit of what's happening with children's behavior. And so we've been working on how to do this in a way that is very scalable, which just means that we can distribute it among thousands and thousands of people, potentially millions of people, but also pretty inexpensive. So technology has gotten cheaper and cheaper over the years. And so this has made it more feasible. And then something which I'll show you in a moment that is able to capture two people interacting at once, because one of the core things we know about autism is that it really expresses itself a lot when there is social interaction. So just quickly, thank you so much for that introduction about myself. I'm a developmental psychologist by training, so I'm not a clinician. So all the views that I take on autism is very much from a research background. So I appreciate all of your generosity. If I say the wrong thing or say it in the wrong way, it definitely happens sometimes. All right, next slide, please. All right, so this is what we call the Dyadic Biosensor. It's our solution to how to collect information from two people who are interacting at once. Because we think that autism manifests in this context of live social interaction, we really need to collect data from both people at once in a social interaction to understand where autism kind of expresses itself. And once we can pinpoint digitally where autism expresses itself, then we can hopefully identify pinpoint areas that can be targeted for intervention. This little device not only collects audio and video that's perfectly time synced and time aligned, but it also has Bluetooth sensors that integrate other kinds of data, things like heart rate and skin conductance, and also accelerometers that people can wear. You can either use computer vision to detect eye tracking, which if anyone has ever tried that, it's actually way harder than it sounds. Or you can integrate it with other kinds of tech that are built for eye tracking. So infrared eye trackers from things like Tobii or iLink. And then the idea is that because all of these data sources are time aligned and time synced as part of the collection process, they're sort of shovel ready to feed into a machine learning pipeline. So here I'm just showing you some of the collaborators that have helped design this. Bob Schultz is the director at the Center for Autism Research. Keith Bartley is one of our engineers who originally kind of came up with this design. And then we also have Casey, Vangelis, and John, who are other PIs at the Center for Autism Research who do various parts of this process. So it's really a big team effort to see if we can design something that gathers all these human signals about interaction. All right, next slide. So this is just an example focused specifically on the face. So each one of these signals represents a piece of this young woman's face as she's talking. So it will detect the corners of the mouth, the corners of the eye, detect head movement. And as she moves different parts of her face, these signals are all being recorded at once. Next slide. So this was laid out really nicely by the speaker before me, but there are multiple potential use cases for this kind of digital phenotyping. And if you just want to click through, I apologize. I usually click things through because it's just kind of how I give a talk, but we'll go ahead and do it all. So one thing that really motivated us was this idea of remote screening and triage. So it's a little known fact, but I was born and raised in Alaska, where there were not autism experts in the early 90s. And my brother went without a diagnosis for years because there was no way to get him a diagnosis without traveling, hundreds and hundreds of miles outside of Alaska to do that. So the idea that you could potentially send a small biosensor out into, a remote part of Alaska or out into a lower middle income country, and get data that could then be uploaded to the cloud, analyzed using machine learning and detected for signs potentially of social communication challenges is very, very appealing to someone like me who has a personal connection with that. Then once you have kind of this remote screening, potentially some triage where you can say, look, this kid is got a few quirks, but really it's not super urgent versus a child who you can tell needs a lot more support. Perhaps we can kind of ease the burden on some of our healthcare providers by helping triage to certain things. Like this kid maybe needs to see a speech language pathologist. This child needs occupational therapy help pretty quickly. This child needs, a straight up diagnosis so they can get hooked into community services. There's also the possibility of using this for diagnostic decision support. Now, I'm not of the belief that, a technology is going to do the full 9 yards when it comes to diagnosing a child. I think that humans are the best at identifying atypicalities in other humans. That's just what our brains were built for. But I do think that it can help support that, especially in the cases of differential diagnosis, where it can be really challenging to determine what are the array of issues that this child has and how can we sort of clump those in a clinically useful way, in a way that's going to help the family get the help that they need and help the child reach their full potential. I think another really exciting opportunity here is using something like this where we have a full 360 actually, 4-dimensional view, because it's over time, of the child's conversational social behavior. It'll highlight strengths and weakness in a way that could help us personalize treatment planning for that child. So if the child's goals are to make a friend, or the child's goals when they're older is to have a job, you could potentially identify weaknesses in their goals and their strengths, and then use them to kind of design a personalized intervention. There's also a lot of interest in using this kind of really fine-grained perceptual computing for drug and intervention response tracking. So folks who are targeting things like social anxiety that maybe you can identify during a conversation. It's possible that you can see whether it's working to help smooth out the conversation or reduce the latency of people's responding. And of course, this could be also used as part of a basic research package. So connecting human behavior during a conversation or an interaction interaction to kind of genetics and brain. And of course, we require very, very large samples for these, which loops you right back to the beginning of sending it out kind of widely and having an automatic upload to the cloud, which of course would need to be protected behind HIPAA and all of that. But in order to develop these really large samples that we can then use to connect to genes and brain. So one of the nice things about this is that the tool is relatively objective. So there are decisions made at every step of the engineering, right? And so from that perspective, there's a human in the loop that's creating this. But once it's created, there's the potential to kind of reduce the impact of clinical biases and expectations that have traditionally led to differential diagnosis in a way that maybe it wasn't best for certain groups. So this might be particularly important for understudied or underserved subgroups, like women and girls with autism, who we know a lot less about. They just haven't been as much a part of research studies over the past 30 years as boys, as well as folks who are gender diverse, who don't fit cleanly into either group, women or boys, or racial ethnic minority individuals. Now, when we're talking about machine learning, there always has to be discussion of the ethics of machine learning, right? Because your data in machine learning is only going to be as good as the training data that you give it. So any of your output is going to be heavily influenced by your training data. And so we think about that a lot, that we can't just train on our usual research samples, because what we're going to end up with is machine learning algorithms that predict very well in our very small research samples and don't really generalize to the larger world. And by the larger world, I mean the whole world, right? Like we also tend to think that, you know, our things that we do in the US predict within the US, but I was really inspired by the goal of this discussion today, because it really is about the world. And so talking about machine learning and technologies and all of that with kind of a world embracing view requires us to think a lot about the ethics. All right, next slide. All right, so this is just one brief example where we used a technology to record all the vocalizations that babies made at 6, 12, and 24 months during the infant brain imaging study, which is 5 or 6 different sites. And kids had clinical evaluations, and during those clinical evaluations, you know, clinicians would make a score, and but the kids would also babble or talk or cry or laugh. And what we decided to do a few years ago was take all those videos that were just sitting on a shelf and go back and say, well, okay, what did this child say? How did they say it? Was it a canonical babble? Was it something that was directed toward a parent? Was it something that was kind of out to the blue, where how much do they cry? How much do they laugh? And what we found is that if you chart these things, which could be at a well visit, 6, 12, and 24 months, right? Like you could record these at a well visit as opposed to a clinical evaluation, and then chart over time, almost like a growth chart, what these children's vocalizations look like. And we did this, and then we used some latent class linear mix modeling to see, are there different groups of kids, clusters of kids that come out if you look from 6 months to 24 months. And what we found is we found 2 different classes of kids. And Andy, if you wouldn't mind pressing the next button. And we found one class where the kids' vocalizations, these are speech-like vocalizations only, they went up pretty dramatically. So they had a nice steep rate of growth from 6 to 24 months. And we found another class of kids whose growth rate in their vocalizations did grow, but it was just a slower growth rate. And what we found was that of our children with autism, 38.4% of those kids, so it should be about 20% in this sample, because these are younger siblings of kids with autism, 38% were in that slower growth group, and almost 15% were in the higher growth group. So there was a split. We tended to have more kids with this phenotype of kind of less vocalization in the lower kind of less steep growth group. What we have now, and which I don't have on here, is we actually have school age follow-up for these kids, and we're able to take this class membership and predict important things about school age outcomes. So based on what we know from 6 to 24 months, we can say something about their social needs at age 10, 11, 12 years old. We can say something about kind of their repetitive behaviors and their language ability as well. So these early patterns that we can potentially collect every so often during healthcare visits using something like a biosensor could help us predict 10 to 12 years later what these children's needs are. So this is just an example, and it's in preparation, but it's not published yet. All right, next. And that's it. Gunafshish, that is Slinkit for thank you. I really appreciate everybody coming here today and the opportunity to share with you a little bit about what we're doing.
Thank you so much, Dr. Parrish Morris, for that excellent presentation on the latest work being done at Children's Hospital of Philadelphia. Now it gives me great pleasure to introduce our next speaker, Dr. Geraldine Dawson. Dr. Dawson is the William Cleland Distinguished Professor of Psychiatry and Behavioral Sciences at Duke University, where she's also a professor of pediatrics and psychology and neuroscience and director of Duke Center for Autism and Brain Development at the Duke Autism Clinic. Dr. Dawson's research has focused on autism early detection, treatment, and brain function. She's an elected member of the American Academy of Arts and Sciences and received the American Psychological Association Distinguished Career Award, Association for Psychological Science Lifetime Achievement Award, and Claire Berry, a top 1% cited researcher across all scientific fields. Dr. Dawson received a PhD in Developmental and Child's Clinical Psychology from the University of Washington and completed a clinical internship at UCLA. I should just also add that Dr. Dawson was also the former CSO of Autism Speaks, and it's great to have her here. Jerry, the floor is yours.
Wonderful. Well, thank you so much for this opportunity. And I want to particularly thank the state of Qatar and UNICEF, ABKU, and Autism Speaks for this opportunity to talk about our digital approaches to early detection of autism and other neurodevelopmental conditions. And today I'm going to be focusing on our work on a novel digital screening and outcome monitoring tool. I should mention that we're also conducting research on electronic health record predictive modeling, embedded clinical decision support in the context of healthcare, and also digital interventions. But I'm not going to have time to talk about all these efforts. So next. So why do we need better screening tools? So we know that signs of autism usually appear when an infant is between about 6 and 12 months of age. For example, a baby may not orient when someone calls their name, may pay less attention to people, may not be babbling or vocalizing, and may show delays in their motor development. And we also know that a diagnosis of autism can be reliably made by 18 months, and yet the average age of autism diagnosis in the US is 51 months, and even much later, as you know, in many low and middle income countries. And this just means that many children are losing out on an opportunity to receive autism-related services and therapy at a young age. So next. Now, there are many challenges with relying solely on parent report based on questionnaires, which is the typical way that we screen for autism. And let me say that we don't think that that we want to eliminate questionnaires. We think they're very important, but rather we think that it's important to integrate this with other forms of information, particularly quantitative information that can be derived from a digital health approach. But we know that questionnaires require literacy. There's many language barriers. We also know that some parents may not have the knowledge of child development to be able to reliably report on the questionnaire. There's known cultural differences in how the questions are interpreted. They do not perform as well for girls or for families of color. And we also know that they do not work as well for families with lower education levels. So next. So our goal is to reduce these disparities in access to accurate screening by providing scalable, objective, and quantitative measures of direct observation of the child's behavior. And I want to point out that my partner in leading this work has been Guillermo Sapiro, who's a professor of electrical and computer engineering at Duke, and his entire team of other assistant professors and students. It's definitely a team effort. So next. We've created a digital autism screening app called Sense to Know, which can be downloaded on an iPhone or an iPad. Next. And the app involves a set of strategically designed brief movies and a game that are displayed on either a smartphone or a tablet. And then the child's responses to these movies are recorded and automatically quantified using the camera that's embedded in the device, and then measured using computer vision analysis. Next. And then multiple behavioral features are quantified in this way and combined using machine learning to provide an objective digital screening algorithm. Next. So here's an example of one of our movies. So this is designed to measure social attention, and you can see that the objects are located on one side of the screen, the woman is on the other side of the screen, and then the camera in the device is able to record the child's behavior. We're interested in many different behaviors in response to a simple movie like this. And all the movies are can be delivered either in Spanish or English. And they also involve very diverse actors in terms of racial and ethnic background. So next. Now, a key feature of this app is its ability to measure multiple behaviors rather than only relying on one behavior, such as a gaze pattern. And we believe this is going to be critical to capture the complexity of autism, which involves many different behavioral characteristics which vary from child to child. So we can measure response to name, facial expression and dynamics, social attention, attention to speech sounds, repetitive behaviors, fine motor abilities, and vocalizations. Next. So I'll now highlight a few examples. And all of this research has been conducted in, do you mind going back? No worries. Thanks. So all of this research has been conducted in clinics and homes rather than in the lab. In fact, one of our studies is being conducted in the low resource countries of Africa. And in our current studies at Duke, parents are downloading the Sense to Know app on their smartphone or tablet at home and administering it to their child, at the time that is convenient for them. So let's take a look at the first example. Next. So while the toddler is watching the movie sitting on the parent's lap, adult in the room calls the child's name 3 times. And a computer is able to reliably measure when the child turns her head and how quickly she does so. So the graph shows data from 611 toddlers who were tested during their well child visit in Duke primary care clinics. And toddlers who were subsequently diagnosed with autism were much less likely to orient to their name. In fact, no autistic toddler oriented to all 3 name calls. Next. Furthermore, when an autistic toddler did orient to their name, they were about 1 second delayed compared to the neurotypical toddlers. And this is a very good example where the computer actually does a better job at measuring this than the human eye, because this delay likely would not have been detected on a parent questionnaire or even by an observant clinician. Next. Now, we've also published several studies on facial expressions, and this is one example. In this study, we used multi-scale entropy to measure the predictability and the complexity of the toddler's facial dynamics. And we found that autistic toddlers showed higher complexity and less predictability in their facial dynamics, suggesting that their facial expressions were more variable and ambiguous. Next. Now, one of the most remarkable achievements of the engineering team was the ability to measure eye gaze using only an iPhone or an iPad without the need of expensive eye tracking equipment or even calibration. And this technology opens the door to studying eye tracking in remote settings using ubiquitous devices. Next. So in this study, close to 1,000 toddlers were tested in Duke primary care clinics in the exam room. And the data that I'm showing here is from 397 toddlers who received the iPad version, 35 of whom were subsequently diagnosed with autism. And you can see that the autistic toddlers gazed more frequently at the toys than the person in the movie with medium effect size. Next. So one of the movies shows two women having a conversation about going to the park. And previous research had shown that by 6 to 10 months of age, infants will actually visually track a conversation, even if they don't understand what's being said. And we found that the autistic toddler's gaze was much less coordinated with the woman's conversation, which is measured as just a simple correlation between the gaze pattern and the speech signal. And you can see an example of an autistic toddler tracking the woman's speech patterns on the top and under a typical toddler on the bottom. Next. So here are the receiving operating characteristic curves and the areas under the curve obtained for models that were trained with, first of all, the individual gaze features that I showed you, the gaze, which is social attention and tracking women's speech pattern, and then their combination. And when multiple gaze features are combined using machine learning, the AUC's discriminating autistic and neurotypical toddlers range from 0.88 to 0.90. And the really important point here I want to emphasize is the idea of combining multiple features to increase accuracy, which is one of the benefits of machine learning. So next. So I hope these few examples have illustrated the feasibility and usefulness of using a computer to measure behavior with a high level of precision and resolution. Our current studies are remotely delivered, administered at home. We're currently conducting a study of an infant version of the app starting at 6 months of age. And then again, we're using machine learning to integrate all of the features shown here into a single algorithm that's now being validated for screening of autism, ADHD, and other neurodevelopmental conditions. Next. I just want to end by thanking my many collaborators to this work, the engineering team. I have a team working on EHR predictive modeling, our primary care providers, and all of our clinical assessors. Next. And then I also want to acknowledge all of our funding sources and especially thank all of the autistic children and their families for their partnership in this work. And I'll end with this beautiful painting of Duke Chapel by Jessica Park, an autistic artist. So thank you.
Thank you so much, Jerry, for that excellent presentation as usual. We appreciate it. You guys been keeping very busy at Duke during the pandemic. Thank you. Now for our next presenter, Dr. Marwa Karakai. She received her bachelor's degree in electrical engineering at Texas A&M University at Qatar, earned her master's and a PhD from Texas A&M University in College Station, Texas, United States. She joins HBKU as a faculty member in 2016. Her research interests lie in the areas of wireless communication, signal processing, and AI machine learning, and the application in multidisciplinary fields. In particular, Dr. Marwa has extensive experience in signal processing and data analytics for development and intelligent detection and predictive models for diverse healthcare applications. Dr. Marwa is passionate and active in research that drives development of personalized learning models to support education of children with autism spectrum disorders. She serves on the board of IEEE Communication Society for the Europe, Middle East, and Africa region, and is advisory board member for Arab AI Summit, AAIS. Dr. Marwa, the floor is yours.
Thank you very much for the introduction. First and foremost, I just wanted to thank the organizers for this event and for inviting me to participate in a very important conversation. For today's talk, I just wanted to discuss the importance of integrating digital health and AI and how such an integration can open up the support to children all over the world who have developmental delays as well as disabilities. So you can go to the next slide, please. There's some text as well. So he already introduced me. So my PhD and my master's were from Texas A&M University. My interest, as discussed, is mainly in predictive analytics, AI. I have a lot of research experience in signal processing, data analytics, especially in developing intelligent detection and prediction models for diverse healthcare application. So this includes epileptic seizure prediction using EEG and ECG data for pediatric patients who have epilepsy, It also includes physiological-based stress detection, which I'll discuss a bit in today's talk, and the prediction of pediatric blood glucose control through HbA1c inferencing. Another topic of interest that I'm very passionate about and active in is research that drives development of personalized learning models to support children's education who have autism spectrum disorder. Next slide, please. So before I started to start the talk, I just want to go ahead and redefine again the term AI. I know that most of us already know what artificial intelligence is, and we have a high level understanding of it. But I think for today's talk, it's important to re-emphasize what AI is, especially in the context of our talk today. And really, on a very high level, AI is basically the ability of a machine to be able to mimic human intelligence. So this includes cognitive ability, which includes the capacity to encompass like reasoning, problem solving, the ability to hold memory, learn, and make decisions and inferences based on a set of data that it sees. So this is the key message here with AI, is that it's able to mimic human intelligence, which is a superior quality of the human race, as we know. However, if we're able to take this, this mimicking of human intelligence and integrate it with computational power of machines, which we know is beyond human capabilities, we have really witnessed a revolution in many of the industries with AI. So this includes medicine, this includes the entertainment industry, security, privacy. We've seen its benefits, and its potential in facial recognition. So the list really goes on. Next slide, please. And one more. Thank you. So I just wanted to highlight that one of the biggest data platforms that we have available to us is the human body. And the human body, as a couple of speakers have already discussed, it really possesses a diverse set of data, rich and valuable information that can reveal so much information about us. It can, reveal our health status, our physical, our mental, our emotional well-being. It can reveal information about what we like, what we don't like, and it can also reveal private thoughts if we're able to capture the proper data and analyze it properly. And now with the advancement of technology, we're able to collect a massive amount of data, human-based data, and we can collect this using relatively simple and low-cost wearable devices. So until now, so all of this data that we're getting, it has a lot of hidden information. And until recently, we didn't have much ability to read into this data other than simple analytical tools that we were using. But again, a lot of this information that we were reading into was very surface level. And as I just defined AI as the ability to mimic human intelligence, and if we equip these machines with proper resources and computational power, then we have the ability to mimic, human intelligence while simultaneously analyzing massive amounts of information, making simultaneous correlations and inferencing on not only large amounts of data, but very diverse amounts of data as well. So this is previously impossible just to do by the previous analytical tools, as well as, the human mind alone. So I think it's very important that we take advantage of this, because we know that AI systems are really as good as the data that we feed into them. So given the abundance of data of digital health, I think the possibilities are virtually endless. Next slide, please. So this brings me to the question of, how can we really exploit the benefits of AI-enabled digital health to be able to support children who have developmental delays and who have disabilities all across the globe? Next slide. And for us to do this, for us to really harness the power that we're able to get from AI-enabled digital health, there's many ways, but among the two that I'd like to discuss today is one through early detection and even prediction of developmental delays and disabilities. And the second is through personalized intervention, which I will discuss each in depth. Next slide, please. One more. Thank you. So as discussed, I think one of the speakers also discussed that oftentimes developmental delays or even autism, they're not diagnosed until a child is 2 years of age, and in some countries even further than that. So this is very unfortunate. It prevents many children from receiving early targeted interventions and care that they can really benefit from. And one of the reasons for this delayed intervention is that many countries across the globe, they don't have the establishment of well visits. So the routine health services that screen for developmental screenings in infants are simply not there. And this is very unfortunate, because early detection and even prediction of such delays is extremely critical in providing proactive action compared to reactive action or even delayed action as we have seen all across the globe. However, if we're able to integrate AI with digital health data, we'll be able to develop screening tools that can predict and detect early signs of developmental delays and provide care in a proactive fashion. So such systems that we develop, they can be utilized by both high-income countries as well as countries that have limited resources and capabilities. And on this note, I wanted to discuss an application of this that uses machine learning to predict the developmental delays in infants. So I'm sure many of us have seen infants, and we've seen the way that why we swaddle them, because they're always moving around and kicking, and they have really spontaneous movements. And there's some groundbreaking research that's underway that shows that these seemingly spontaneous arm and leg jerks and movements in newborns and infants, they can actually encode information about typical and atypical development for that child. And there's preliminary research that's found that the use of wearables like the motion movement, you can capture motion movement through different kinds of ankle and wrist watches, and then train a deep learning model on it. Research has found that you can find or predict whether that child will develop some kind of developmental delay within the first 6 months of that child's life with around 83% accuracy. So this is actually very profound finding. Even though it's initial findings, it's quite profound. And if we're able to push this more and do more research into this area, this would be very revolutionary for many countries across the world, particularly countries that have limited resources in terms of screening and doctors and care for children who have such delays and disabilities. Next slide, please. So another way that we can support children who have developmental delays and disability is through personalized intervention. And here I really want to stress the word personalized, because we've come to see time and time again that this one-size-fits-all narrative isn't suitable across many domains. And this is particularly true when we're looking at children who have varying degrees of delays and disabilities. And in my opinion, one of the biggest ways that we can support a child that has these disabilities and delays is to provide them targeted and personalized therapies and educational opportunities. And now that we're in the era of AI and big data analytics, this is very feasible. So I wanted to discuss, what do we mean when we say personalized intervention? So what we mean is that, in research in the literature, and as well as in my own research findings, we've seen that our own body, as a human body, it responds to stimuli differently. So we respond to diseases, medication, external stimuli very differently in a unique manner. So this is why personalized medicine, for example, is gaining so much attention and research interest in this era of AI. So personalized intervention is what we want to administer intervention in one of two ways. One is we want to administer it in a time that the most suitable for the child to benefit from. And the second is that we want to be able to administer it in a method that the child will benefit from. So the time and the method are quite critical here. And in order for us to do this, we really need to analyze their digital health data strategically. And this means understanding the message that's being relayed from their bodies. So this is the key point, is that we need to shift from subjective methods. And although questionnaires and evaluations are important, but data that's coming from the human body, data that cannot be consciously adjusted, for example, like your physiological data, information like this serves as a ground truth. And we should be analyzing this data to help us develop customized treatment plans and educational plans for each child that is unique as them. So in the past, like I've said, this seemed like a daunting task, but now with AI's ability to analyze large amounts of diverse data, we're able to develop such personalized learning strategies and customize them to maximize the benefit for each particular child. Next slide, please. So next, I will just briefly discuss some of the research that we're conducting at HBKU and in my group. One of this research I'm engaged in is also in collaboration with Dr. Dina Athani, is on the development of head pose-based attention assessment method for children who do have autism spectrum disorder. So we've all heard the phrase, or maybe it's been said to us as well, to sit up and sit straight and pay attention. But is it really that simple? And the answer is no. And it's even bigger no to children who have autism spectrum disorder, mainly because they're characterized by sensory processing abnormalities, and they do have difficulty paying attention. So the aim of this research is to be able to develop an attentional assisted method for children who do have ASD based on the child's head pose and the head pose movement. And for order for us to do this is that we've developed an attentional task where an experimental study actually, where we invite children who have ASD to participate in augmented reality attentional tasks, where simultaneously we're collecting a cohort of information while they're performing this task. So we're collecting, eye gaze information, facial information, as well as their head movement. And once we have this set of data, what we're doing is extracting pertinent information about their head pose, the head position, the frequency of movement, the direction of movement, and then feeding this information into a deep learning network along with the outcome of the attentional task, and then being able to tell whether the child is or isn't paying attention given a particular task. Now, the ultimate goal of this research is to be able to develop this head pose estimation-based attention assessment so that given a camera that you set up in a room, it can provide real-time information on whether that child, is paying optimal attention or isn't really, focusing in the content just by the way that they're moving their head and the movement of their head. So this can go also a long way so that we can, provide support to teachers and educators and therapists when and when not to engage in intervention, so not to waste time for both the child and the teacher, and help decrease frustration. Next slide, please. Another research that I'm working on is on the development of non-subjective stress detection using physiological data. So we know that children often exhibit hidden emotion. And this hidden emotion, it could be stress, anxiety, it could be depression, or they could feel sad. It deters their ability to benefit from therapy or education. So it's really important for us to be able to determine the emotional state of a child, despite what that state is. And the reason it's important is because, one, if we're able to determine the emotional state of a child before we provide them intervention, then we can actually avoid doing it at that particular time and wasting efforts and increasing the frustration for that child. Two is that if we're able to identify the emotion of the child while we're performing a particular task or while we're giving them a particular intervention method, then we're going to be able to assess whether that particular educational task or the way that we're providing the assessment or the intervention is really suitable for the child. If the child is stressed or unhappy during the time that they're receiving this therapy, then sometimes children, they mask it very well. So we can't tell, even as adults, we don't know if we're feeling stressed or anxious until sometime afterwards. And this is particularly true for children. So it's important for us to be able to understand this in a non-subjective way, to be able to read into their bodies and understand this. So for this effort, we've embarked on a data collection effort that uses wearables through the form of a wristband to collect a number of physiological data. And with advanced signal processing and deep learning networks, we're able to classify with high accuracy given this data, whether a person is stressed or not stressed. And then we're pushing it even further to be able to determine what's the stressor type. So is it a physical, cognitive, or social stressor? And the outcomes of this research will really help shape, personalized learning, personalized intervention, and help us get the proper care and optimize the care for children, with developmental delays and who need particular care. Thank you.
Thank you, Dr. Marwa, for that presentation. I'd like to now invite all our panelists to join me on the screen for a brief interactive conversation. And one more, Dr. Parrish-Morris. Dr. Parrish-Morris, great, terrific. So thank you all the speakers for their excellent thought-provoking presentations. Clearly, there's been some rapid advances in digital health research in recent years. Please share with us, each of you, your thoughts in terms of opportunities as well as challenges related to the introduction, implementation, adaptation to scale of these innovative solutions that you've described. Let's start with Dr. Alfani, please.
Sure, of course, Andy. Actually, I just wanted to highlight that I really enjoyed the talks by all the speakers. It was really amazing and very inspiring. I think for research and from a research perspective, I think we have a long way to go. And why is that? First of all, is reaching to the implementation level and reaching to the end user, as we call it in technology sense. It involves several stages, and including like the IP, the patenting, reaching the market. And this is something we are going through at Hamad bin Khalifa University. We have a lot of products that we would like to share, but we then go into these challenges, and sometimes these challenges are such a bottleneck for us to go ahead with. So that's one of the main challenges I see from my perspective, from where I am. Although I feel there is a lot of opportunities, this consortium is one important opportunity that we need to take further to reach to stage that these technologies and these innovations are really helpful in changing people's lives. So that's my take on that.
Thank you, Dr. Dina. So yes, I totally agree that the consortium affords an opportunity trying to accelerate the work that we're trying to do. Dr. Parrish Morris, your thoughts, please.
Yeah, I echo a lot of the kind of barriers highlighted by Dr. Al-Thani. It's definitely a huge leap, I think, sometimes from the clinic or research out into the real world in practice. And it's something that I know to make a technology like ours global, we can't do it on our own, right? It requires collaboration across the world from different like-minded folks who have the same goals to provide access for kids around the world, because really, we can only operate from our own perspective. As much as we try to, be world embracing in our perspective, we really need collaborators. So I think that that's one of the wonderful things about this forum here is that, there are now people around the world who I've seen and who I have names for, who might be potential collaborators. But really, I think one of the things that I struggle with is how to make this meet the urgent needs of kids who are out there right now, because there are so many barriers to implementation, and figuring out how to eliminate those barriers and provide access for kids right now, I think is something that we really at the Center for Autism Research are kind of struggling with and haven't traditionally been that successful with, because we're not in other places right now. So hearing other people's ideas and thoughts on how to do that more effectively and in a way that is super respectful of the places that we're going into. Because we don't want to go into a place and, have a solution for everything that may not be sensitive to the culture that we're entering. So figuring out a way to do that in a way that's very conscious and sensitive it feels like a whole nother field. It's like you do your research and you've got your expertise, and then the idea of actually putting it out there is like, well, I need brand new people on my team who have expertise in relating to other humans. So yeah, so this is a nice way to bring all those issues to the top.
Thank you, Dr. Julia, for highlighting the need for collaboration, as well as the need to really engage community in meaningful ways, so we can produce knowledge together and solutions together. Jerry, your thoughts, please. Oh, you're muted.
Yep. Let me also say how much I enjoyed the talks. Just really, I learned so much, and I'm very inspired by all the work that's going on. So I'm going to quickly make 3 points. One is that what we're finding in terms of the success of these digital health approaches is that when you're thinking about designing a tool, whether it's intervention or screening or outcome monitoring, it's very important to design it integrated in the context of an entire clinical care pathway, right? So not to think about an app or a tool in isolation, but how it's going to function right from the get-go, from the very first study of how it would function in a pathway of care. An example would be the MChat, which I love, and I'm so happy that we use the modified checklist for autism in toddlers here at Duke with thousands of toddlers every year. But it turns out that people will use the MChat, the providers, but they don't actually make a referral. So we found that about only 25% of providers actually make a referral based on an MChat. However, if you add clinical decision support, which is an automated tool that comes up that provides support for making that referral, you can increase that to 85% of people making a referral. But referral is just the first step in this clinical care pathway. So that's the first thing. The second thing is this idea of user-centered design, and those are very closely related concepts that we really do need to, from the get-go, think about the context that we're going to use these tools and involve the people who will actually be affected, providers, families, autistic individuals, in the design and implementation of the studies. This is basic implementation science rules that are so important in the context of a digital health approach. And then a piece of that is understanding the extent to which people need to be involved in the implementation. So there's a lot of nice research now that looks, for example, at if you do an intervention that involves a touch point with a person versus just trying to have people use things on their own, what is the rate of compliance? So we really need to think about adherence and to the extent to which these can operate in isolation or with people. And then the third thing is just the need for very rigorous clinical trials, because this is a new area of science. And I think in order for the world to view the science, I think with trust and with respect, we're going to really need to bring a lot of rigor and reproducibility to the work that we do. So those are the 3 points I would make.
Thank you so much, Jerry, for highlighting the basic principles of implementation science and the importance of working together. Thank you again. And last but not least, Dr. Marwa, your thoughts, please.
Thank you very much. Again, I think we've come a long way. I also echo the same concerns as the speakers here today. That I think one of the important issues that we have to address is visibility to the community and to the end users. This is a very important subject. With new technology comes sometimes some resistance. So it's important to educate the society, educate the people about the research that went into the technology, I believe, provide some transparency on how it's working, especially when we're using AI. So AI also, it has so many benefits, but then there's some people who are also quite reluctant when it comes to AI and privacy and transparency. So if we're able to do this acceptance, I think it will be easier to kind of integrate into society, introducing these tools both in the clinical and academic setting. And if we do this, it will actually help. It was like a loop that will come back in the research setting. So then we motivate the community in terms of the technology. It will motivate and in terms of the research. They'll be able to maybe do better user studies and recruitment if we showcase the outcomes and the success of this research. So I think this is something important that we should be looking into. Before we think just how to introduce technology directly. But maybe let's engage the community, engage these families, engage the clinicians on what went into the technology, and have some transparency there as well.
Thank you, Dr. Marwa. I'm grateful to all the speakers for really highlighting the importance of engaging the user, the community of stakeholders that we're trying to serve. So because of time constraint, I regrettably must bring the session 1 and 2 to close right now. I want to thank again our distinguished speaker for sharing their cutting edge work with us and for giving us a lot of things to think about in the upcoming sessions. As I mentioned earlier, for our third interactive session toward integrated ecosystem of comprehensive identification assessment intervention, we have invited several key stakeholders, including policymakers, community organization, ethicists, and research professionals to reflect on what they have heard and share with us additional perspective. Each panelist will first provide a brief opening statement before we dive into questions and open the floor for interactive conversation. Please allow me to introduce our first panelist, Professor Hans Frostberg. Is a professor of neuroscience at Karolinska Institute and a consultant in neuropediatric at Astrid Lindgren Children's Hospital in Stockholm, Sweden. He's one of the founders of the International Alliance for Academies of Childhood Disability, has been its first president. He's past chairman, European Academy of Childhood Disability, past dean and past vice president, Karolinska Institute, and past member of the Nobel Committee for Physiology or Medicine. He's president and expert advisor in a Unicef project developing, implementing, and evaluating global recommendations for early identification and intervention for children with developmental delay and disability, particularly in lower resource settings. Hans, the floor is yours.
Yep. Good morning or good afternoon, everybody, and thanks, Andy, donors and organizers, and previous speakers. Your lectures have been very informative and inspiring, and I think we have a future ahead. So you heard the background. So I'm actually started as a basic neuroscientist and then turned into a neurologist doing clinical work and research. But now I am an expert advisor for a project under Dr. Löwe, who introduced these talks in a project led by Dr. Raul Bermejo and together with Diane Damiano at NIH. And our purpose is really to see that all children with disabilities very, very early get intervention and support for their development. Because we know, as several of you have said, that we have a window of opportunity during the first years. And we also have now emerging evidence that early interventions actually give much, much better results than if we are coming in much later. So from this, I will actually, from the other side, you have shown now what wonderful techniques we have. I will give you 6 challenges. So coming out to low and middle income countries, because that's where the majority of children are living. I thought first that we should just improve their knowledge and how to treat these children, but I saw a completely different reality. And the first thing was actually how many children on the globe have a disability. And the answer is nobody knows, because in most low and middle income countries, there are no data. So that means we definitely need to have good data to achieve that. Now we make estimates from data from high income countries that it's about 1 in 10 children. The other one was that it was not really the medical side which was the problem, it was a stigma, and that children with disability and their families were neglected, discriminated, and excluded. So in this project, we are really emphasizing strategies for communication and advocacy so that we can have a social and behavioral change in the society, so these children will be included. The next we found was that due to the stigma, so for example, in Uganda, there it's a shame to have a child with disability. Usually it's the mother who has done something wrong, i.e. extramarital affair, or there is something other, there is a witchcraft or something. So that means they are actually hiding their children with disability. So that means that we now need to have an active universal screening where we early are finding children with developmental delay and disabilities. And next, when we have found them, some of them really need, for example, as we heard, children with autism spectrum or with cerebral palsy, they really need to have further assessments in order to give specific interventions. We also know that due to the stigma that children with disability, that they are not included in mainstream services like nutrition, health, and safety. So this is really now important that we are opening up these services for children with disability, which also means they have to be adapted. Fourth is that children now who are hidden away, excluded, and don't get support, they are not reaching their developmental potential. So therefore, in this project, we have had international experts who have developed evidence-based recommendations, which now will be implemented in different low and middle income countries to their context, their health system. And that means that caregivers will be educated and trained through a cascade of training at national, district, and community. So the sixth one here is that if this now is proven efficient, this program, we need to spread it globally. So that means that we need now to develop a system, maybe centers of excellence, where we really now can introduce, train, support other countries now to implement this. So here I have the 6 challenges. We need to have good system for data collection at the global scale. We need to develop and disseminate communication and advocacy. We need to develop screening and assessment tools. And there we have actually seen a lot of examples today, but can they be used in low resource countries? We need to develop support and intervention, that is intervention with evidence-based methods. And there I think we have a good potential. And finally, to spread. So this is my response to this is a challenge. Can we solve? Can we scale up? Can we become much more efficient in our vision now to reach every child everywhere? Thank you.
Thank you, Dr. Forsberg, for those thought-provoking words. I'd like to invite our next panelist, introduce her. Ms. Kiran Manku is a researcher in the University of Oxford. She works in the Global Initiative of Neuropsychiatric Ethics, where she conducts research and provides ethical advice on advances in diagnosis, prevention, intervention, and anti-psychiatric developmental disorder. She has 32 young people across 5 African countries to co-create ethical guidance on mental health apps for young people across Africa. Karen also has a younger brother with severe learning difficulty and autism who motivates and distracts her from her work. Finally, Karen is also a fellow of the Royal Society of Arts and a participant in the Moral and Ethical Advisory Group within the UK government. Karen, the floor is yours.
Thank you so much, and thank you for inviting me to be here. It's been really insightful to hear about all the kind of digital innovations and the science and the technology that's going on. As Andy kindly explained, most of my work is looking at ethics and kind of engaging young people and co-creating guidance with them. So that's kind of what I want to speak about today. And I also want to highlight that actually high quality care is really difficult to achieve in high income countries too. And I mean, my personal experience is always that, you know, you have to shout a lot, you have to have good network, and it's the same. There's so many gaps in high income countries too. So I also feel like we shouldn't say that, you know, that's the gold standard. For me, I think high quality care is really a blend of good legislation or guidance, good people, and good resources, wherever that way may be. And I think digital health is a critical resource that could be upscaled to address many healthcare gaps across the globe, really. But ultimately, digital health can't be without adequate contextualization and regulation. And I think both of those things are critically important. And actually, when we think about digital health assessments and interventions, there are various ethical tensions that need to be addressed. And I'll speak about these from case studies and experiences of work that we've been involved in. So particularly to do with assessments, I found that it's really important to consider non-maleficence or avoiding harms. So specifically, this is about being careful not to apply our own lens to a different context. And I know this was just spoken about in some of the concerns, and I think it's great we're having these conversations and discussing things like implementation science and co-creation and what that actually means. And I think it's particularly important when we're looking at measuring behavior, especially when we know things like mental health and cognitive disorders are both expressed, understood, and discussed in different ways across different contexts. So when you're measuring that, the measurements would have to be different as well. So one example is similar to the app, looking to track interactions in measuring autism, and this was used in India, so it's still in development. And actually, we found that the concept of using technology for the assessment provoked a fear amongst certain families. And they kind of felt that if this digital technology could say that my child has a disability, everyone will know, and it kind of promotes a sense of stigma. And that's not to say it shouldn't be used, but it just means that you have to provide adequate information about it. So it's about, if there's a fear, how do we explain more about the digital technology? How do we have conversations with families to understand what information they need and how do they want this information disseminated? So that's one of the issues, the ethical issues that could easily be addressed by the things we've been discussing, like co-creation and implementation science. Another example that I can give was a partnership with Harvard, who are collecting DNA across different African countries to investigate the genetics relating to mental health and across developmental disorders, specifically autism and ADHD. Similar to actually the previous colleague who just spoke, we found that DNA increased the blame put on mothers, as it was seen that actually women pass down their blood and DNA, whereas fathers pass down their behavioral characteristics. So when you then look at examining DNA, it places more blame on women. And how can we ensure that that's not the case? Well, again, it goes back to, how do we explain what DNA is and how do we ensure that that's put across in a way that won't place blame on women and you know, put them in a more difficult situation, and it's already probably a stressful situation. So yeah, it's basically, rather than importing the consent process from the States, we actually took 18 months almost to design a new consent procedure with local communities to avoid any discrimination and stigma. And this was like it was a lengthy process, but ultimately we were able to have a more engaging consent process where we asked people, do you actually, like, do you understand these things? And only if you understood certain things, you actually had access to the research or the treatment itself. And it's very much about allowing people to digest information, allowing them to go home, which traditionally you don't do with protocols. You normally like bring them to a room, let them explain there. And it's about allowing them to share it with their family and using their context in which they're comfortable with. So yeah, I mean, when we're talking about developing these assessments and measurements, I think we do have to think more about the local philosophies and values about populations, and that can be done through co-creation. So looking at, you know, who's working there in the field, just kind of reaching out to different people. And I know sometimes many people are like, well, where do I start? And I'm like, you can just Google and start. That might not be the person you need, but eventually you will get there. And that sense of co-creation is really what we need. And I'll be brief because I know we're short on time, but I also wanted to give a couple examples specifically in regards to the digital health innovations. So I've been working with 32 young people across 6 African countries. I wanted to work with a diverse group of young people. So some are victims of sexual abuse, some have HIV/AIDS, some are members of the LGBTQIA community in countries where it's still illegal, and some are just like market workers, many who don't speak English, like people like fishermen, work with the fishermen community. And I really wanted to get their opinions on what they want to see in terms of digital mental health technology. And it took much longer than I anticipated, actually. I thought I could, you know, deliver some training and explain, you know, the different types of digital technologies, explain about ethics and kind of get them to address or unpick some issues that they might think of. But actually it did take a lot longer than anticipated, one with the pandemic and everything being virtual, but also two, just having to break things down so much further and them not having access to resources. was really hard. But yeah, I provided many different trainings, both myself and my colleagues, across different health innovations, ethics, and then trained them to work with other young people to go out and ask for their opinions. And then we actually co-produced a digital campaign highlighting the key ethical issues. And from them, there were kind of three main ethical issues that they want addressed. The first is about confidentiality. They're very concerned about where their data is going, what will happen if their personal data is being exposed, who has access to it, which types of healthcare professionals. And especially you have to bear in mind, many have phones that are shared with others. So how is it password protected, but still available, you know, with limited access to data or energy? The other is also affordability. So it was really important that young people want apps that are accessible to all. They want them to be cheap, if not free. They want it to be integrated with their local healthcare provision. And they want you to think about the local infrastructure. So thinking about low bandwidth, how can you deliver it on that? How can you have mechanisms to change the coding procedures? Because you can work with local coders who know all these like really interesting things that I don't understand because I'm not a coder. But yeah, those things came out really important. And the third thing I'll mention is about informed consent. They really wanted to understand and be able to either accept or deny certain elements of consent and where their data is going and how it's being used and how much of the app they want to be able to access. So having that element of control over the app was really important for them. And so I have put these young people in a network with other local stakeholders, including local policymakers, app developers, and this includes like Google Africa. So they have the opportunity to showcase their own ethical issues to these stakeholders so that hopefully we can create good guidance to make sure that these emerging digital tech innovations are what the local populations want to use. And that will also help make sure that they are used worldwide. And that's what we want, because we all have the same aim, but it's sometimes about including them in that legislation or guidance process. So yeah, I hope this has given some insight into the role of legislation and guidance in creating good digital health. And I'm really excited about this consortium, and I think we can definitely do a lot of good work together. So thank you so much.
Thank you, Ms. Karan. And thank you for reminding us the importance again of engaging community in really meaningful way to co-create knowledge and solutions for the community we're trying to serve. Next, I'd like to introduce Margaret Grobelna, is an equality and human rights lawyer, a mediator, and advocacy representative at the Jim Foundation, a Polish NGO supporting autistic people and members organization of Autism Europe. Ms. Grobelna builds acceptance for autistic people and focus on changing legislation in Poland, especially to adopt comprehensive autism strategy that addresses the needs of autistic person and their parents. Her main interest lies in the rights of disabled persons, especially the implementation of the Convention of Rights of Persons with Disabilities. She's also interested in autism research, focusing on a holistic approach. Ms. Grobelna, the floor is yours.
Thank you so much. I would like to start with a thank you to everyone who made such brilliant presentations and delivered such great speeches. And I also wanted to thank for the invite to this great forum. As my remark, I would like to say that there are so many documents that recognize the early child development as one of the critical domains of global importance. And so many documents that bring the attention for the need to change to our life course perspective to ensure that children reach their developmental potential. And those needs are in par with Jim Foundation's mission to create a better world where every autistic person can realize their full potential. That's why researchers, practitioners, and advocates strive to ensure that we have the right tools to make that a reality. And probably technology might be the answer to that need. We have seen the instances of digital health having the potential to reach so many families who are geographically distant from major urban centers of provision. We're certainly seeing that with COVID. The potential to be a bridge to families who, for whatever reason, may be reluctant or skeptical about a diagnosis. As the former speaker said, there is the cultural stigma that is a big issue in many communities. And digital health might be a cost-saving, less time-consuming tool for practitioners to aid them. And being able to collect longitudinal data to track and model progress over time, look at what predicts good and bad outcomes, is definitely a big advantage. But I also want to be a devil's advocate in this discussion, because when we are talking about autism research, we often talk about small samples, lack of studies concerning specific topics, insufficient data. And sometimes, although we need more data, that doesn't always solve things, all of the issues and problems. Usually when we collect data, it is done by humans, and we are often inconsistent in this task. For example, diagnosis is based on behavior, and so it's subjective. It means the data we are submitting to machine learning is inconsistent across raters. It's definitely affecting the accuracy of outputs from machine learning, and large data sets are not necessarily the way forward because we just keep increasing the error in data. And so we are better looking at refining tools to improve consistency across raters or to reduce error. It is also important to think about the willingness of practitioners to use new technology in their work, the care providers, to have the basic legislations to put this work forward. And clearly we have to explore if the advantages outweigh the risks. However, we also have the responsibility to use the AIs, the machine learning, the technology in research and in clinical approach only to improve the quality of life of autistic people. Because at the end of the day, their comfort and they having their needs addressed is the most important thing. As I mentioned initially, it is crucial to ensure that children reach their potential and can live fulfilling lives as adults, even if they have high support needs. Therefore, our priority should be to use that advantage of algorithms and data mining to create a better world for autistic people. Probably providing a quick, affordable, and accurate diagnosis in a rural area with machine learning or other AIs might be just the start of the happy journey through life for autistic people. And that is what we should strive for.
Thank you so much, Ms. Corbena, for those thoughtful words, and especially highlighting the need to really make sure that the training set that we use for AI machine learning are really well balanced and we represent the community we're trying to serve. Thank you so much for that. Last but not least, it's my pleasure to introduce Professor Onar Barak-Dursun. He's a professor of child and adolescent psychiatry and the head of Department of Autism, Mental Special Needs and Rare Diseases and Ministry of Health in Turkey. Dr. Dursun, the floor is yours.
Thank you so much. I think I have a presentation, and can you just, yeah, that will be more effective for 3 minutes. As Andy said, I'm the professor of child and adolescent psychiatry. I'm from Turkey, and I'm also the head of department for autism, mental special needs, and rare disease in Turkish Ministry of Health. It's a new thing for me. So next, please. Mentioning about Turkey, it has a key role in the region, geographically, religionally, historically, and there are countries who has Turkish roots around, and we are also a candidate for EU for years, and we have 80 million population, which 1/3 is under 18, and 1/3 of that is under 2 years of age. And we are one of the most youthful nations of Europe. Additionally, we are hosting around 6 million refugees from around, especially from Syria. And for this, today's topic, these are important numbers. 70% of all the total population are social media users in Turkey, and around 90% of households has access to internet. Next, please. In terms of developmental problems, we don't have the exact numbers, but we know that it's more than 10%. And a study conducted by us shows that we have 1% of ASD among children. And the official number says 68,000 reported cases are being diagnosed in state hospitals in a year in Turkey. And 17,000 are being diagnosed with ASD. So next, please. The role of Ministry of Health is, we are one of the most powerful systems in Turkey in comparison with the Ministry of Education and Social Affairs. And all health expenditures are covered in Turkey for children for free. And we have a strong family medicine system following up babies from pregnancy, and the vaccination rates are so high in the country. These are our strengths, and I'm all mentioning about the real life issues, just bringing this resource data to real life. It's important to concentrate on your strengths first. So we created a nationwide autism recognition and referral model, which we used an interactive video-based training. And we reached out to 2 million kids to date. It brought us a semi-academic unit for developmental disorders and autism in the ministry, that I'm the head of the department now. And we've started for 20 plans, projects in a broad perspective. I'm so happy to see Dr. Dawson here, because one project is about ESTM, and on the other side we have Center for Excellences. So we have a plan to implement digital health systems in this projects. And the other strengths of the country is we have an advanced health registry and health informatics systems that we can base our projects on. Next, please. I will give some examples because I know the time is not enough. We have an app that 42 million users are using it in the country, a smartphone app. Both health professionals and citizens can reach health records from there. So it's one of the best ones in the world, and we can establish a strong communication between people with disabilities and physicians from here. So we are working on a project, just we can use this Navas app for our purposes. Next, please, Andy. And the other examples are from our fields. In the time of pandemics, we wanted to help kids online, and we created 2 apps and 2 systems, which we integrated in our health system. One is for children with mental special needs, and the other is children and the healthcare workers and their children to support their psychiatric situation. So they really work well. I will not go into detail now. And next, please. And the other thing we did was, we had nothing in our hands for autism screening, and all the system pushed us to screen, to use a scale-based screening. But this is not suitable for most of the countries. So we thought something else. A video, interactive video-based education model. Next, please. And now we reached out to 2 million people, 2 million kids, which we diagnosed nearly 6,000 cases for developmental disorders, other developmental disorders, and 3,000 kids for autism. They were just sitting at their home. So next, please. To conclude, we are so proud to be here first. And as an academician who is now working in the government, that's awful and that's a nightmare. but I can say I did more than I expected. And you have to know what you have in your hands and in your system first. And we can say that we are ready for the next steps that we discussed earlier in the morning today. You have to start with small steps first. That's my last message. Thank you very much.
Thank you so much, Dr. Onar, for sharing with us the really impressive progress that's being made in Turkey relative to digital health on a national basis. Really pretty incredible. Because of time constraint, I'm afraid we're not going to have time for more interactive conversation among the last group of panelists. What I'd like to do now is actually invite Dr. Dina Althani to come back and to share with us some news about the consortium that we've been discussing here. Dr. Althani, the floor is yours. Let me bring up your slide.
Thank you very much, Andy, and I would like to thank all the panelists for a very interesting insights, in fact, from a different perspective, which is really important in enriching this consortium and this discussion, in fact.
Apologies, 1 second. Thank you.
Thank you, Andy. Just to conclude this important event, we would like to announce our intention in creating this global digital health consortium to support children with development delays and disabilities. And actually, this idea stemmed from some discussions myself and Raul from Unicef and Andy from Autism Speaks earlier this year, in which we had these several discussions and can you go to the next slide? Yeah, it has animation, but you could go through the animation. So the idea is actually spanned from all the discussions we had today, those fruitful discussions on how to support meaningful and timely services and intervention in healthcare to support children with developmental delay and disabilities. We all know that early intervention plays a key role, whether we are working basically in research or in practice or in policy or in government services and ministries. We all know that early intervention is the key. However, how can we support this to the basically the different levels of services provided by the different areas and countries around the world, given the differences in economy and development in these countries? So how can we bridge the gap in capacity building as well as in service providing in all around the world? And as many of us stated in this session, that we all know that 10% of children around the world that may have developmental and disability disorder will not be provided with the right intervention in the right time, in fact, and might not provided at all. So we thought of initiating this consortium to support the work that UNICEF, the important work that UNICEF is taking ahead in supporting children around the world. Can we go to the next? So the idea is to develop the global digital health consortium with these 3 stages, as you can see in front of you. First of all, we'll start, as we did today, to consolidate the innovations around the world. There is a lot of beautiful work done all around the world. So how can we consolidate that, and how can we think about the delivery of these technologies and these high-tech, basically evidence-based research to the world, thinking about the next step, which is having a platform, a unified platform to put all these technologies together, and from there accelerate their adaptation, their testing, their implementation. We've all discussed as well, basically testing on different populations and the bias that AI can come with, and how can we expand testing and expand the implementation. So putting all this into one consortium of people in research, practice, and implementation. Next slide, please. We came up with this basically very modest plan, I would say, in achieving this in the year of 2022. So as I said, we started in the initial months of this year in discussing this idea. Then we have the announcement of this consortium today. This announcement of intention of establishing this global consortium. We are in the stage of seeking co-conveners to support this consortium, whether from research expertise level as well as in funding level. The second stage would be establishing the global consortium, defining its steering committee, the governance, establishing the funders, the conveners, and creating a group of expertise, which we hope that people with us today will be part of the group of expertise establishing this consortium. And hopefully we hope to announce it toward the end of this year as a working establishment under the umbrella of the UNICEF.
Thank you so much, Dr. Dina, for summarizing our plans going forward and the vision for going forward. I just want to thank all the participants again today for joining us and sharing not only their expertise, but also their perspective about both the opportunities as well as potential challenges in developing a global consortium, as Dr. Dina had described. Clearly, I think such a entity will do much to accelerate both the research and the implementation of the solutions that have come out of research. Some of them have been shared by our speakers today. And we look forward to working with all of you going forward to make this consortium a reality and to start delivering high-impact solution to all of our children around the world, especially those who are currently not able to benefit from the advances of research in autism and developmental disability services. I will here now then like to bring this session to a close. And I want to thank all of you again for joining us, and we'll follow up soon with the next steps, and have a wonderful day. Thank you.